Thank you for the invitation to participate in this virtual CME. I'll be speaking about the use of echocardiography, pitfalls and tips in detection of pulmonary hypertension. I have no disclosures. Today we're going to be speaking about understanding the context by which echocardiography is done and integration of the qualitative and quantitative aspects of the examination. We'll go over what a good TR signal is and offer some tips in terms of how to improve this important Doppler assessment. We'll contrast the use of the tricuspid regurgitation velocity with actual calculation of right ventricular systolic pressure, paying close attention to what we define as the right atrial pressure. And lastly, we'll speak about the implications on outcome and why it is important for us to be as accurate as we can be. In terms of understanding the context, it's important to know the types of patients that come to your echo lab. Your pretest likelihood of having pulmonary hypertension would depend upon the severity of illness of the patients coming in. If you are in an inpatient setting or in a pre-transplant setting, you can rest assured that the pretest likelihood of finding pulmonary hypertension is going to be higher in your lab. It is also important to integrate the quantitative information with what you see in terms of the actual images themselves. We will highlight some of those examples upcoming. In this paper by O'Leary, they looked at specifically whether the lack of a tricuspid regurgitation Doppler signal plays a role in detection of pulmonary hypertension by invasive measurement. In this population, there was a high pretest likelihood of having pulmonary hypertension. All of these patients were scheduled to undergo right heart catheterization within 2 days of the echocardiographic examination. Patients had a high preponderance of congestive heart failure, ischemic heart disease, known pulmonary hypertension, or underlying pre-transplant assessment for heart, lung, or liver disease. In his cohort of over 4,600 patients, more than one-third of patients had no tricuspid regurgitation signal. In this population, almost half of the patients had underlying pulmonary hypertension. In contrast, in the patients with defined signal of tricuspid regurgitation, approximately 2/3 had pulmonary hypertension defined as a mean pulmonary pressure of more than 25 millimeters of mercury. Therefore, the absence of tricuspid regurgitation should not be seen as the absence of pulmonary hypertension. This is the distribution of pulmonary pressures in the groups with and without a detectable tricuspid regurgitation signal. You will notice that there is a tendency towards a higher pressure in those with detectable tricuspid regurgitation. Clinical predictors of the presence of pulmonary hypertension include the presence of left atrial enlargement, right ventricular dilatation, and dysfunction, as well as the presence of heart failure, the presence of diabetes, and high body mass index. The British Society of Echo have proposed a way of actually assessing the presence or absence of pulmonary hypertension by expanding upon the previously defined categories outlined by the European Society of Cardiography. They suggest looking at the qualitative features within the right ventricle, the pulmonary artery, or the inferior vena cava and right atrium, and determining whether there is or is not the presence of abnormalities qualitatively in 2 or more of those structures. By incorporating the actual tricuspid regurgitation velocity, together with these echo categories, we can have a better definition of whether the presence of pulmonary hypertension is seen to be of high probability, intermediate probability, or low probability. Whereas a patient who has a tricuspid regurgitation velocity of more than 3.4 meters per second surely has a higher likelihood of pulmonary hypertension. A velocity that's less than that may still be associated with pulmonary hypertension if there are more echo qualitative criteria involving the right ventricle, pulmonary artery, or the right atrium, as I'll show next. A right ventricular abnormality is defined as either right ventricular enlargement, that is, the basal width of the right ventricle approximating the left ventricular width, or the presence of septal flattening. Visually, basically, it is just a definition of the minor axis of the left ventricle in the plane that is parallel to the septum, being greater than that perpendicular to septum, such that the eccentricity index exceeds 1. A pulmonary artery abnormality is defined as dilation of the pulmonary artery of more than 25 millimeters, or the presence of an early pulmonic regurgitation velocity of more than 2.2 meters per second, or a shortened pulmonary acceleration time on pulse wave Doppler of less than 105 milliseconds, or the presence of notching within a pulmonary artery signal on pulse wave Doppler. And lastly, a right atrial or inferior vena cava abnormality is defined as right atrial enlargement of a right atrial area on the four-chamber view of more than 18 square centimeters, or the typical dilatation of the dilatation of the inferior vena cava more than 2.1 centimeters with impaired respiratory variation. All this still hinges upon the presence of a good tricuspid regurgitation signal, because the incorporation of the qualitative information still takes into account our ability to estimate that right ventricular signal. This group here from Stanford looked at how we can actually improve the ability to estimate right ventricular systolic pressure, and they compared it with pulmonary artery pressure with cardiac catheterization. They found that if you could define what a good tricuspid regurgitation signal is, you can have an area under the curve which predicts pulmonary pressure with very high precision. We know from the previous work from Chumla that there is an excellent correlation between hemodynamically derived mean pulmonary pressure and systolic pulmonary pressure, such that a systolic pulmonary pressure of 38 millimeters mercury on cardiac catheterization generally correlates with a mean pulmonary pressure of 25 millimeters mercury, which was the old standard for defining pulmonary hypertension. Therefore, being able to correlate non-invasive echo-derived pulmonary systolic pressure and correlating this with the systolic pulmonary pressure at the time of cardiac catheterization is extremely important. In this slide, the authors suggest that a good tricuspid regurgitation signal is one in which there's a complete envelope together with a clearly defined point, so we can define what the maximum velocity is. A fair signal was one in which the images were a bit fuzzier, and a poor quality signal was one in which it was very hard to discern the velocity at all. In the group that had the highest proportion of good signals, the accuracy of estimation of right ventricular systolic pressure was greatest. The authors also warn us that it's very easy to overestimate the Doppler assessment of right ventricular systolic pressure if we turn the gain up too high. We have to pay close attention to minimize the gain so that we can get the velocity, or so-called motor velocity, of the majority of the blood cells. Shown on panel B is an estimate of the actual velocity with proper gain, and at the same time overgaining and leading to overestimation of the right ventricular systolic pressure. Shown in this panel, the authors also highlight various other pitfalls, that is, use of a Doppler signal that is not parallel to the flow of blood, leading to underestimation of the tricuspid regurgitation velocity. Overgain is also demonstrated. And lastly, one can get a much better appreciation of the maximum velocity if we turn the sweep speed a bit faster to allow us to see the fuzz and discern the fuzz or the overestimation from the true motor velocity. This is demonstrated in the bottom right-hand corner. This is one of our examples of a patient who clearly has septal flattening and is suspected to have pulmonary hypertension. In this signal, on the left-hand side, you can see that there is an angulation problem such that the path of blood flow is different than that of the Doppler signal, leading to underestimation of the right ventricular systolic pressure. On the bottom right-hand corner, you will notice that the maximum velocity can be estimated, but the example here is that of over-exaggeration due to lack of consideration of the motor velocity. You notice that in this particular example, when actually compared to right heart catheterization, that the velocities reported in this study were in fact overestimated due to those pitfalls identified. In fact, the presence of a good tricuspid regurgitation signal depends upon the underlying disease. In people with primary pulmonary arterial hypertension, there is a high likelihood of a good quality or fair quality signal, whereas in those patients with anatomic lung disease, such as COPD or pulmonary fibrosis, more than likely the presence of tricuspid regurgitation produces a poor signal. When the authors compared a level 3 reader with that of the right ventricular systolic pressure derived on cardiac catheterization, they found that there was relatively good agreement and that the levels of disagreement were usually related to a not well-defined tricuspid regurgitation signal. Less well correlation was seen between right heart catheterization and that reported in the clinical report, with errors found not only in the incomplete signal of tricuspid regurgitation, but also overestimation due to lack of consideration of the modal frequency, as well as sometimes an underestimation of the right atrial pressure. This slide highlights the correlation between echo and cath-derived right ventricular systolic pressure, depending upon whether the reader was a level 3 reader, a level 2 reader, or whether it was just reflected in the clinical report. Notice that the line of agreement is much better with increasing levels of experience, as reflected in the tighter fit on the regression line on the left, as well as the tighter fit in the Bland-Altman plot on the right. In terms of suggested tips, not only should we choose the best window for alignment of the tricuspid regurgitation signal, but we should also adjust the sweep speed to a higher sweep speed, avoiding premature ventricular contractions, reducing the Doppler gain and avoiding extrapolation of the signal, and pay close attention to the modal velocity. Saline contrast may be helpful to define and discern signals that are not complete. And lastly, and we'll talk about this later, we need to use multiple methods of assessment of the right atrial pressure. This is a publication from a journal looking at transthoracic echo in children. You notice that in the publication there is overgain leading to overestimation of right ventricular systolic pressure. So this occurs not only in your labs, but also in published literature. On the two panels on the right, a poor tricuspid regurgitation signal can be enhanced by the use of saline contrast. But remember, saline contrast can also lead to a shaggy signal and leading to overestimation of the actual pressure. Well, what about if we were to use different levels of tricuspid regurgitation? Does the presence of severe tricuspid regurgitation affect our ability to estimate the right ventricular pressure? In this paper, they looked at patients who had varying degrees of tricuspid regurgitation, and they found that the presence of severe tricuspid regurgitation was a major determinant in being able to overestimate right ventricular systolic pressure. Whereas there was relatively good agreement with no systematic bias between echo and cath-derived pulmonary pressure in those with mild to moderate tricuspid regurgitation. In those with severe regurgitation, there was a tendency towards overestimation of right ventricular systolic pressure by echo Doppler. And in fact, severe tricuspid regurgitation was the only variable detected on multivariate analysis as a parameter leading to overestimation. And we know from other studies, most of that is because of inaccuracy in the estimation of the right atrial pressure in the presence of severe right, tricuspid regurgitation. And this has been termed the Achilles heel of echocardiography when there is significant tricuspid regurgitation. This has further led investigators to consider, should we use the actual absolute velocity of tricuspid regurgitation rather than calculating right ventricular systolic pressure? Surely then we can obviate the situation by not having to estimate the right atrial pressure directly. And these authors actually did just that. They looked at 136 patients and whom they had either right heart cath as well as echocardiography. They wanted to know which was a better predictor. Well, it's pretty well a wash. If you look at the receiver operated curve, the right ventricular systolic pressure did about as well as the actual tricuspid regurgitation velocity. And whereas the right ventricular systolic pressure had a higher sensitivity, it had a lower specificity in detection of pulmonary hypertension compared to just assessment of the tricuspid regurgitation velocity by itself. And a lot of this has to do with non-invasive evaluation of right atrial pressure, which can be problematic. We all know that from the various guidelines that we should look at more than just the inferior vena cava. In fact, dilated inferior vena cava would diminish respiratory collapse is just one parameter to indicate an elevation in right atrial pressure. Other parameters, which I will go over subsequently, are also important. In addition, inferior vena cava dilation can occur in the presence of normal right atrial pressure under various conditions. The degree of respiratory variation can also help, but depending upon the study that we use, we might find different strata for determining the actual right atrial pressure, depending upon the degree of respiratory variation. Shown here are two patients, one on the left and one on the right. You notice that the right atrial pressure may be high in both situations. The inferior vena cava certainly is dilated. However, the patient on the right has a dilated right atrium, and though not shown on this non-moving picture, there is also bowing of the interatrial septum from right to left. And this distinguishes the presence of high right atrial pressure in this individual as contrasted to the other individual who had a dilated inferior vena cava in the presence of normal right atrial pressure. Further information can be derived from the systemic vein Doppler signal. On the left-hand side, you notice a superior vena cava pulse wave Doppler signal of a normal individual demonstrating systolic preponderance of flow. In the hepatic vein signal seen on the right, the systolic wave is smaller than the diastolic wave and is reflective of elevation in right atrial pressure. Another method of assessing right atrial pressure or enlargement in right atrial pressure can be determined using pulse wave Doppler of the tricuspid inflow and comparing this with the tissue Doppler velocity. Panel A on the left demonstrates an E wave velocity of 84 centimeters per second across the tricuspid valve, and when divided by the E prime velocity at the tricuspid valve annulus, this is under 6. This signifies a normal right atrial pressure. The patient on panel B has a smaller absolute E wave velocity, but when compared with a very low E prime velocity, that ratio is greater than 6, reflective of an elevation of right atrial pressure. In fact, we should be using more than just the inferior vena cava, and this paper highlights that the importance of not just looking at one characteristic, but looking at multiple characteristics to determine whether in fact the right atrial pressure is elevated or not. Well, why is this all important? We know that the more accurate we can be, the more precise we can be, and it has implications in terms of the outcome of the patients. In fact, Strange found that the threshold for detecting pulmonary hypertension may be actually a lot smaller than we think. And they associated the presence of pulmonary pressure with mortality in 313,000 patients in this Australian cohort. The distribution of right ventricular systolic pressure is outlined here. And you'll notice that most patients didn't have very high pressure. However, regardless of whether you look at quintiles of pulmonary pressure on the right or absolute numbers on the left, a higher pulmonary artery pressure was associated with increased mortality and increased cardiovascular mortality, as exemplified by a reduction in the cumulative survival curve. And even mild degrees of pulmonary hypertension, around 40 to 49, may be associated with abnormal outcomes and increased mortality. This is not the only paper. Other studies, as demonstrated in a systematic review and meta-analysis, have shown that even mild degrees of pulmonary hypertension can be associated with increased mortality. And that's independent of whether the assessment of pulmonary pressure is determined quantitatively using right heart catheterization or qualitatively using echocardiography. Notice, however, because of the inherent variability in the signals of right ventricular systolic pressure by Doppler, the fit is much better with right heart cath. What's important about this is because increased mortality is associated with even milder degrees of pulmonary hypertension, this has contributed to the redefinition of pulmonary hypertension being defined as of 2019 as a mean pulmonary pressure of more than 20 rather than 25 millimeters of mercury. In summary then, I've taken you through the integration and need to analyze not just the quantitative signals, but also the qualitative information within the echocardiogram. It's important to obtain as good a tricuspid regurgitation signal as possible and to be as precise as possible in estimation of the right atrial pressure in order to derive the estimated right ventricular systolic pressure. mainly because the detection of even mild pulmonary hypertension has huge implications on the actual outcome. Taking this back to your lab, it's important to have quality assurance with both your technologists and your physicians, and make sure that your reports go out with qualitative and quantitative information such that the isolated value of right ventricular systolic pressure is not the only thing that's reported. And lastly, be aware of even modest elevation in right ventricular systolic pressure. I thank you for your time, and I look forward to your questions and comments. Thank you.